Hey, it's Dr. Pillai. Now, many patients that wear scleral lenses, whether it's for keratoconus or dry eye, they may be wondering what are we as doctors looking at during the evaluations? Well, there's two important things we're looking at. One is the vision, the optics of the lens, and the second is going to be the actual fit. How is that scleral lens aligning with the actual ocular surface? So for vision, first we're looking at the optic zone, what diameter that is on the surface of the lens, and what kind of power changes we need to make to give optimal vision. So that could be increasing the power, decreasing the power, modifying and adding what's called front surface toricity, which is basically astigmatism correction onto the front part of the lens. So there's lots of different ways we can adjust the actual optical portion of the scleral lens to get the achieved visual results we want. Now, what's newer on the optical side is adding wavefront optics. So if you ever heard the terms like nearsightedness, farsightedness, astigmatism, those are what's called the lower order aberrations. Well, there are also higher order aberrations, which go beyond that we can now measure with wavefront guided instruments and then incorporate that into the optics of the scleral lens. This is where a lot of the newest research is coming into scleral lenses. So if you hear things like higher order aberrations or wavefront guided optics, that's what it's talking about. Now, the second important part is the actual fit of the scleral lens. How is it aligning with the scleral tissue for that patient? So we're looking at what's called the toric haptics or the spherical haptics of the scleral lens. The haptics is the edge of the lens. We want to make sure it's not impinging on any of the blood vessels. It's not causing any blanching of any of the blood vessels where it's too tight. We also want to make sure it's not too loose either. That can cause lens awareness, can cause discomfort issues and excessive movement. Aside from the periphery, the haptic, we also come in a little bit closer to where the cornea meets the conjunctival tissue, this area called the limbus. This area is very important. We want to make sure that the area is not impacted by the scleral lens at all. It's vaulting over it because this is where a lot of the limbal stem cells are. So very important to keep the limbal area nice and healthy, no kind of contact with the scleral lens at all. And then also the central corneal and the mid-peripheral cornea, you want to make sure there's adequate clearance across the entire corneal surface. The whole point of the scleral lens is that it doesn't interact with the cornea. It's not touching the cornea. It's vaulting completely over the cornea to make sure that cornea can rehabilitate if there's not the surface issue, but also to make sure the landing is completely in the periphery onto the scleral tissue. So I hope that gives you some insight into what we as scleral lens doctors are looking at when we see our patients behind the microscope. So I want to make sure we, one, prioritize vision to make sure that we get the best visual outcome we can, but also that the ocular surface is not being impacted by the scleral contact lens. I hope that helps.